This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we're diving into a topic that sits right at the intersection of functional neurosurgery and thoracic surgery, a procedure that changes lives but often comes with a frustrating trade-off.
And I'm Dr. Alara, Research Fellow. Today, we're looking at a fascinating new study from the Journal of Cardiothoracic Surgery, published in June 2026. The paper is titled T2 Sparing versus T2 Including Sympathectomy for Hyperhidrosis, a meta-analysis on compensatory sweating.
This is a perennial debate in our field. For our residents listening, we're talking about primary hyperhidrosis. It's more common than people realize, about a 1 to 5% prevalence, and it usually starts in childhood or adolescence. When medical management fails, endoscopic thoracic sympathectomy, or ETS, is really the gold standard for definitive treatment.
Exactly. And while the success rates for stopping palmar or axillary sweating are incredibly high, we always have to counsel patients on the Achilles heel of the procedure, compensatory sweating, or CS.
Right. And the incidence rates in the literature for CS are all over the place, anywhere from 3 to 98%. It can be a minor annoyance, or it can be a debilitating condition where the patient's chest, back, or thighs are suddenly drenched. I've had patients tell me they'd rather have the sweaty palms back. So the question has always been, can we modify our surgical technique, specifically the level of ganglionic resection, to minimize this?
That is exactly what this meta-analysis by Delgado and colleagues aimed to answer. They specifically looked at whether sparing the T2 ganglion makes a statistically significant difference compared to including it in the resection.
Let's talk about the scope of this study. Meta-analyses live or die by their inclusion criteria. What did they look at?
They conducted a very thorough systematic search of PubMed, Embase, and the Cochrane Library up to July 2025. They ended up including 11 studies with a total of 3,090 patients. It was a pretty even split. 47.2% of patients had T2 sparing procedures, and 52.8% had T2 including procedures.
That's a robust sample size. 3,000 patients gives us enough power to really see a signal through the noise. What were the primary outcomes they focused on?
The big one was the incidence of overall compensatory sweating, and perhaps more importantly, the incidence of severe compensatory sweating. They used random effects models to calculate pooled odds ratios and assessed heterogeneity with the I-squared statistic.
Okay, let's get to the results. If I'm a resident in the OR and I'm deciding whether to take that T2 ganglion or stop at T3, what does this paper tell me?
The data is quite compelling. T2 sparing sympathectomy was associated with a significantly lower incidence of overall CS. We're looking at an odds ratio of 0.38 with a 95% confidence interval of 0.21 to 0.67. The p-value was 0.0009.
An odds ratio of 0.38 is a massive reduction. That's more than a 60% reduction in the odds of developing compensatory sweating if you spare T2. But what about the severe cases? Sometimes overall CS includes mild sweating that doesn't bother the patient.
That's a great point, but the trend held up for severe CS as well. The odds ratio for severe compensatory sweating was 0.43, with a confidence interval of 0.28 to 0.64. The p-value there was even more significant, less than 0.0001.
And what about the consistency of the data? Often in these meta-analyses, you see 1 or 2 large studies driving the whole result.
They accounted for that. They performed leave one out sensitivity analyses, and the findings remained robust. They also did subgroup analyses looking at randomized versus non-randomized studies. Both subgroups confirmed the results.
One thing I always worry about with hyperhidrosis studies is the follow-up time. Sometimes CS takes a while to fully manifest, or patients adapt over time. Did they look at the duration of follow-up?
They did. They split the studies into short-term follow-up, which they defined as 12 months or less, and long-term follow-up of more than 12 months. Interestingly, the benefit of T2 sparing was consistent across both timeframes. It wasn't just a short-term honeymoon period. The reduction in CS persisted.
That's critical for patient counseling. Now, let's play devil's advocate for a moment. In some older observational studies, the inclusion of T2 was thought to be necessary for high success rates in palmar hyperhidrosis. Does this paper address whether sparing T2 compromises the primary goal, stopping the sweating in the target area?
The meta-analysis focused primarily on the complication of CS. However, the authors note that the level of sympathetic chain interruption is a modifiable factor. While some believe lower levels like T3, T4 might not be enough, this study reinforces that the T2 ganglion is a major trigger for the compensatory response. The conclusion the authors reach is that we should avoid T2 when feasible to minimize postoperative morbidity.
It's a classic less is more scenario in neurosurgery. If we can achieve the same therapeutic effect by only targeting T3 or T4, why take the extra risk of T2? The paper mentions that previous evidence was inconsistent, but this meta-analysis seems to provide a much clearer picture.
Exactly. They mentioned that a previous meta-analysis by Lin and Lin identified things like BMI, age, and smoking as risk factors for CS, but that study didn't actually evaluate the specific surgical level of the T2 ganglion. This new study fills that gap in the literature.
Let's talk stats for the residents for a second. They reported an I-squared of 65% for overall CS. That suggests some moderate heterogeneity. How should we interpret that?
65% does suggest that there are differences in how the studies were conducted, perhaps differences in surgical technique, patient selection, or how compensatory sweating was defined and measured by the patients. However, the fact that the sensitivity analyses and subgroup analyses all pointed in the same direction suggests that the core finding, that T2 inclusion increases CS, is likely true despite that heterogeneity.
Right. And for the severe CS group, the I-squared was much lower, wasn't it?
Much lower, only 19%. That gives us a lot more confidence in the result for severe CS. When you have low heterogeneity like that, it means the studies are very much in agreement that sparing T2 protects against the most debilitating forms of compensatory sweating.
That's a key distinction. We can live with a little mild sweating on the back, but it's the severe cases that lead to patient regret and dissatisfaction. If sparing T2 reduces those odds with an OR of 0.43, that should change how we approach these cases in the OR tomorrow.
The authors are quite direct in their conclusion. They state that their findings support avoiding T2 when feasible. They do call for more prospective studies to confirm these results, but with 3,090 patients already accounted for, the weight of evidence is certainly leaning one way.
This is a great example of why we keep up with the literature. ETS is a relatively old procedure, but we are still refining the nuances to improve the quality of life for our patients. If you're a trainee listening to this, pay close attention to your levels next time you're in a sympathectomy. Precise localization of that T2 ganglion is more than just an anatomical exercise. It's a major factor in your patient's long-term outcome.
And it's a reminder that even though the procedure is technically straightforward, the physiological consequences of where we disrupt the sympathetic chain are complex.
Well said. I think that covers the main thrust of the Delgado paper. Any final thoughts on the methodology or the data?
Just that no publication bias was detected, which adds another layer of confidence to these pooled results. It seems to be a very clean, well-executed meta-analysis.
Excellent. Well, that's all the time we have for today. Thank you, Dr. Alara, for breaking down the data. To our listeners, we hope this helps you in your clinical practice and your boards.
Thanks for having me. See you next time on the Neurosurgery Hub podcast.
Until next time.